NG tube. A lot of times, even after a couple of days, when the patient has an NG tube, they'll develop an ileus after the fact. So you make sure you listen to bowel sounds, see if there's distension, all that kind of stuff going on with patients. But they can actually, you can take it out and they can start eating, maybe on clear liquids, full liquids, and they develop ileus again. So the NG tube has to go back. But that's common in older people. I already know if I got a person 70 years old doing it, I can pretty much know, like clockwork, 4th day they're going to have ileus, because it tends to happen a lot for them. The other thing is you got to control their blood pressure. Because if I did an anastomosis and I put something in this patient, I got to control their blood pressure, because if the blood pressure goes high, I can rupture whatever I put in. So a lot of these patients will be on nipride after surgery, because I need to control their blood pressure. They also, when they go home, have to control all the same risk factors we did before. Stop smoking, control your blood pressure, cholesterol drugs. Common theme, right? Because atherosclerosis is the underlying cause for why this is happening with your patient. But no symptoms initially. And a lot of times you'll see the pulsation below the xiphoid process. You hear a pulse, it's just like you're listening to somebody's chest. But normally people don't have signs and symptoms associated with it unless it ruptures, which is the bad part. Okay, when you have an abdominal aneurysm rupture, if they have an anterior rupture, meaning it ruptures forward, that means it's going into the abdomen. That means every heartbeat you're exsanguinating. So every time the person's heart beats, blood is going into the abdomen. So when you have a person that has an anterior rupture, you usually see a very distended abdomen, it's full of blood. Okay. When you have a person that has a posterior rupture, it means it's going to the back. You got a little more time. Because patients who have abdominal aneurysm rupture, unless you're in a place right now where you can have surgery, usually die. That's just the nature of what happens. Because with every heartbeat, this person is bleeding out. They're exsanguinating essentially what's going on. With a posterior rupture, because you have the spine in the back, a lot of times you can actually get clotting there. So you got a little more time. You still got to fix it. But a posterior rupture will actually clot off a lot of times. Patient will still be symptomatic because remember they lost blood. So you're going to see shocky signs and symptoms. But if you have a posterior rupture, it's a better outcome for the patient. But usually no signs and symptoms. If you have a person that does have an aneurysm, before they decide they're going to do surgery, because at about 6 centimeters is when doctors say you need to have surgery. Because they measure it. That's what you go to have routine testing for. But if you have a patient that does have one and they're not to the surgical point yet, but they do have one, you treat upper respiratory infections right away. Because remember, anything that increases intra-abdominal pressure can make them rupture. So if they have a really bad cold and are coughing really hard and sneezing all the time, they can rupture an aneurysm. Sounds like, well, how can that happen? How thin the walls of the vessel are does that. If you have a person that's in a car accident, seatbelt pulls you. That causes increases intra-abdominal pressure that can cause an aneurysm rupture. So it's stuff you have to monitor for, because some patients, their doctor will tell you, you need to drive around in the car and put a pillow in front of you. Not just, you're going to get the airbag, but you need to put a pillow in front of you when you're riding in a car, because that's how bad it is. Sometimes they do that because patients have poor surgical risk. If we put you under the knife, you may end up dying in this kind of thing. But most patients, when you talk about aneurysm that starts to bleed or they start to tear or they start to rupture, unless you're unless you're in unless you're in a level 1 trauma center, or it's during the day if you're in a level 2, will you make it? Level 1s mean I have somebody in-house to do surgery 24 hours a day, 7 days a week. Level 2s mean I have somebody 30 minutes out. And the reason I say during the day is because there's always a vascular surgeon in-house. They'll actually call it over the intercom. I need any vascular surgeon to come here because they're going to do surgery on the patient right away. When you have a thoracic tear, which means it's higher up in the thoracic cavity, you usually have people that they'll tell you that sometimes they'll have a cough. They may have a change in their voice quality. They feel like a tearing almost when they're doing that. But they can also present with the signs and symptoms of an MI. So a patient looks like they're having a heart attack. But if you treat it like a heart attack, the patient's going to die. All right? Because what happens is it's splitting open, so you're going to have the same exsanguination stuff, but now it's going in the chest as opposed to the abdomen. The most famous patient, his wife won a whole lot of money because they treated him for an MI, but he was having a thoracic aneurysm rupture, was John Ritter. When he did at Gulf 3's company.
Jack.
Yeah. When they treated him like he was having a heart attack, but he had a thoracic aneurysm rupture. So they're treating him with all this stuff. Guess what? He's bleeding out, but you're giving vasodilators.
Oh, my.
You're giving nitrates. She was already rich, but she's real rich now, kind of thing. But that's the thing. It presents just like a heart attack. So you work it up that way because he's the right age. You know, he fits the description of somebody who could be having a heart attack. But, you know, those are the things that happen sometimes. But it presents just like a heart attack. You have chest pain, but that kind of thing that's different. People who are having a heart attack don't tell you I feel like something tore open. A lot of patients do tell you that. That's the feeling. They feel like something is tearing. Since most of them don't live to tell it, when you hear somebody saying that, that's what you go, yeah, okay, let's look at that. So those are kind of things you're looking for in the patient. But they do happen. So then we have our acute arterial occlusion. This is the one with the 6 P's. We kind of talked about this way back somewhere before. But acute arterial occlusion tells you just that for some reason I have a clot that is blocking the artery. So now it's causing, if I don't fix it, it's going to cause death to tissue. So this is a person that usually is going to interventional radiology to have some type of embolectomy or to instill medication at the site. The arteriogram is going to give me the best picture because remember that's vascular system that's involved. So I can see where it is. I can go get the clot if I'm doing embolectomy, or I can instill medication at the site of the clot. That's the same thing you're doing. I'm dissolve it, hopefully reestablish circulation. But those are the 6 P's. Remember, pain, pallor, pulselessness, because you lose the pulse.
Why keep it going?
It's cold. You can't move it. And numbness and tingling. All right? So those are the things you see. What I need to do is reverse this process. If I don't, the patient can lose that extremity. And always think about time is tissue. So the longer you let this go, the problem that patients can have. Because that paresthesia that you have that maybe is transient right now, but the longer you leave it on somebody, it can be something that lasts for weeks to days. I mean, it's from days to weeks. Sometimes after it's like, got it backwards. Okay? I gave y'all an example when I had my thyroid surgery blood pressure cuff on so long. I had pain and paresthesia moving my hand, but that numbness and tingling lasted for almost a month after my surgery. It was really bad for a while because I couldn't even hold a fork. I'm right-handed and I had to start eating with my left hand because it hurt so much to just do simple stuff. You don't realize about things that you just do in life that you cannot do because your hand hurts. But it got better and better, but just think that's why time is tissue. So the longer you let it go, the more likely a patient can have problems. Because the same kind of thing when you think about, we always talk about foot drop when you're in nursing school about making that bed. And people think, oh, it's not a big deal. If you leave that foot in that position for 20 minutes, it can be permanent. So that's why it's always important to make sure simple stuff you can do for a patient you want to make sure you do. But those would be the signs and symptoms you see associated with that. And then last but not least on the structural hip parade is cardiogenic shock. Now cardiogenic shock is actually in that little handout I gave you. Talk about what happens with your patient. This usually happens when we talk about cardiogenic shock is essentially the heart is not able to do anything it's supposed to do anymore. Okay? So we talked about the pumping force of the heart being lost because that's usually it. It's a mechanical loss of function of the heart that we see associated with it. So we have devices we can use to kind of help you along and augment function until we get that back together kind of thing or help you get better. But cardiogenic shock is the worst case scenario of any kind of the cardiac stuff that happens with your patient. So now, and this is one of those kind of general things, all shock states in general produce the same kind of things, but they're not always the same. All right, I know it's kind of crazy, but some of the things that we do that are essentially the same. Initially, what your body is going to do is try to compensate for what's happening. So initially, when you see a person in cardiogenic shock, heart rate increases, blood pressure goes down. But it's only for a short time, because cardiogenic shock is weird in that the blood pressure goes up later. Okay, so heart rate increases, blood pressure down initially, then it goes up. In most shock states, they will tell you patient needs fluids, because if you put a body in anaerobic activity, a lot of it is because you can't get a waste products, all that kind of stuff. So they need volume to do that. But remember, the heart can't pump efficiently, so sparingly do patients get fluid in cardiogenic shock. There's only 2 shocks where you don't use a lot of fluids. Cardiogenic is one, neurogenic is the other, but it's for a different reason. Cardiogenic is because the heart can't pump it along. Neurogenic is because in the neurogenic patient, the vascular system is dilated. So basically what you're doing is pouring water in something that's not moving anything. So a small amount of fluids you're going to need for that patient. You got to watch them carefully, because you can actually make the heart failure worse, that kind of stuff, when you're talking about cardiogenic shock. So what we get into is using medications that are going to help the pump work better. So those are the positive inotropes, those types of things. So positive inotropic drugs. We may also give this patient some of those devices, balloon pumps, ventricular assist device. Because the heart has failed, I got to give you something to augment function until I can take care of the issue that the patient has. So that's where I'm not going to ask you about what is a VAD and what is an inner aortic balloon pump. Just know we use those to actually augment ventricular function until the patient is more stable. So you're trying to get hemodynamics. I'm just telling you what it's about. Because remember, your NCLEX exam is a basic care exam. If you end up working in these places, remember, you're going to get another course. Because I tell you, EKG course is 24 hours. Advanced EKG course, another 24 hours. Progressive care course is usually 60 hours. So all that you're going to do along with those areas that you work in. So don't feel like you got to know everything when you graduate from nursing school. When you go into those areas, you will get extra stuff. What you have to think for yourself is, what is the worst case scenario? Because I got to think about what's happening with this patient. When you got a patient who is in cardiogenic shock, and you're going like, they should be stable, but I see all the signs and symptoms of heart failure, that's when you start worrying about the patient going in that direction. Especially after an MI, because that's where it happens most often. It happens in other stuff too, but that's where you're going to see it most often. Patient's going to start off doing their regular thing, recovering. All of a sudden you see this person get flash pulmonary edema, flash heart failure, then the heart doesn't work very much at all anymore. So you start giving meds. I'm going to give you stuff to try to help with your blood pressure. I'm going to give you stuff to try to help increase kidney perfusion. That's when they go on all those drips. When none of those things no longer work, compensatory mechanisms are not working, did all the meds and stuff that I can do, you're still not perfusing, still not maintaining blood pressure, then you're going to do some type of assisted device to help the patient. So that's where the balloon pumps come in. That's where the ventricular assist devices come in. And one of the ladies that I saw at the hospital, week before last, is, or last week, I saw her with UT students. I had asked her about being a preceptor. She actually works night shift, and she floats right now. But she used to be, she was an LPN student now, who gone on and got her BSN. But she left Tampa General because she worked on the transplant floor, and they were giving them 5 patients, and one of those patients was a VAD. She said there is no way, and it's true, if you got a VAD patient, that's the person who has a ventricular assist device, there's a lot of stuff you got to do to make sure this patient is cool. Now, of course, people go home with VADs and all that kind of stuff, but if you're in the hospital, you're having a problem. So to give somebody a 5-patient load and one of those is a VAD is not a good thing. She left. She said it's not safe to do stuff. So every place has their issues about what's going on. And I was telling students, I said, you know, she would love having somebody work, because she already gave me her name. She would be a preceptor for somebody. But I'm telling you, she's going to keep you on your toes. She's going to ask you questions about what's going on with your patient. She don't play. So I told this girl, I said, I would do that. I said, she would eat you. In my head, I said I don't say that to her.
Oh, man.
It's not in a bad, but she's going to make you, she's going to ask you questions. And most of the people, especially when you're talking about ICUs, CCUs, that kind of stuff, they're going to ask you stuff about patients. And they don't expect you to know everything, But they will tell you, I need you to research it, come back and tell me. They'll tell you that in a heartbeat. You learn a lot from them. But I'll tell you, if you want to, that's somebody who's going to have to want the challenge, though, because Rose will get you. But she's a good nurse, that's the thing. And she started off just like you guys. She came through our program and went to work at Tampa General. Worked there for a long time. Became the clinician for transplant unit. And then she went back to staff just because she didn't want the, you know how it is when you work with people sometimes. You need a break from being management type thing. And but she said the patient assignments were just crazy. That is when you worry about your license. You work too hard for this, for people to give you that kind of assignment. She said, I just couldn't do it anymore. So now she floats. Now I have several people that work in ICU, but they're the same way. They're going to ask you stuff about patients. You know, why is this going on? Why is this happening? They don't expect you to know at the beginning, but as it goes along, they're going to keep asking you those things to see why do you think we're using this drug, kind of thing. So if y'all up for the challenge, let me know.
Which hospital?
Huh?
Which hospital she's at?
Florida Hospital. What is that? Like, the guys go, no way.
I'm good.
All right. So for the other stuff that we had, because we're going into GI, because you guys have already done HIV, because the other class has to do HIV, because you already have your certificate. But we're going into GI stuff next. We're also going into blood products and that kind of thing. So I'm going to just do that blood. Did y'all decide what y'all want to do first? I didn't ask y'all that. Or did y'all vote? Oh, y'all want to tell me tomorrow? I don't know.
Voting about what?
Missing class this Monday?
Yes.
Yeah, so we can study.
She studied for the test on Tuesday.
What we have to do?
How long do we
Study.
I think we need to listen to the
Oh,
question now.
What time will we be
Today and tomorrow, or
Just today.
What time is it?
the way?
Wednesday is clinic. So just.
How long are we staying here today, if we stay here today?
So I get done. What are you talking about?
What's that?
12?
12, 1, 2?
2 p.m.? 3 p.m.?
I would love to take off Monday.
To study.
Of course. That's just one rule.
She has to.
New material.
So this is the stuff that's going to be on your following exam, but your quiz is sepsis. So what I need you to make sure you do is go to the CDC website. And look at the Surviving Sepsis campaign. Did you guys look at the sepsis video?
Some of the links did not go when I clicked on them.
Oh, that's because they copyrighted stuff.
Oh.
They take stuff down when they find out it's copyrighted. You can't link it anymore.
Oh, it says you do not have permission to.
That's what I'm saying. If they find out something is copyrighted, then they take out the link.
Oh.
So that means that between last semester and now, somebody had copyrighted stuff on there, so you can't do it directly as a link anymore. Because they were all there last semester. But once somebody finds out that they've copyrighted something they have, then they do that. All right. So I need you to go to the CDC website, look at the Surviving Sepsis campaign. Okay, because for you guys have already done HIV, so that's their quiz for my basic classes work on HIV, so they can get their certificate. But sepsis is a big piece of what we try to prevent patients from having in the hospital now. What you want to do tomorrow when you're in the hospital is print out a sepsis protocol. You may have heard, because a couple of times we've been in the hospital, they had sepsis alert. What do you do for that patient? What are you monitoring for in that patient? So thinking about those people at risk, but that Surviving Sepsis campaign, knowing when you do lab work, what medication is supposed to be initiated for a patient, what are some of the prevention measures that kind of go along with that. Okay. But all of that's going to be on your CDC website. Septic shock piece is going to be on the exam next week. If you give up a day to study, that's what it's gonna have to be, one or the other. Because we can either do the quiz on Monday, or you can take it to study and you still have to do that. I'm just saying.
So everything we need to know for this quiz is on the CDC website, Surviving Sepsis campaign.
Exactly.
And when is the quiz?
After the
Tuesday
test.
after the test.
On Tuesday.
And the lectures and tests for
I don't know. When we supposed to be studying for the test on Tuesday? We
No,
never
And
be
the
studying
quiz.
for the
Monday.
study for both.
No school Monday because they're going to be studying for the test, but there's also a quiz after the test on
What
Tuesday.
usually happens when you have a quiz for something like this? Because y'all smoking crack right now.
You usually give us the evolve thing to do.
You get an evolved thing to do, but what happened when you had your HIV quiz?
was open book,
Open
It
book.
was, oh,
Open friend, open friend.
open text.
call a friend, open book. Okay.
Open friend.
Take off
All right. So the next section that we're going to go into is,
No, we can't.
these will be things that we talk about, because this has to do with the RBC pieces up here, I'm going to talk about today. And then we have WBCs, platelet disorders, the lymphomas. We talk about patients who have hematology stuff. And then the GI is always going to be the acute stuff for GI. So it's GI blood loss goes in there too, but it has acute pancreatitis, that kind of stuff. So we'll talk about that kind of thing next week. But I'll finish the hemorrhage and hemorrhagic shock now, and the use of